Welcome students to MBBS Online Lecture 2021 YouTube channel. The topic for today's lecture is about embolism. Previously, we have discussed thrombosis in detail, also its many clinical manifestations. So, for the homeostasis, embolism is the last topic. So, let's discuss it. First of all, the definition of embolism. We have given an overview and a brief intro of embolism in thrombosis lecture. What is this? It's a basic dislodged mass of thrombus that is carried by blood to a site distance from the point of origin, where it blocks circulation leads to infarction. As you can see in this picture, this is basically the bifurcation pulmonary artery. There is a form emboli that blocks the circulation at the site where the arteries bifurcate. So basically, this travels from the deep vein leg present in the leg to the right side of the heart, then from right side to the pulmonary artery and blocks at that side. So emboli can be solid, liquid or gas. Majority of emboli are derived from thrombus that we call thromboembolism, while 1% of the emboli are fat, air, amniotic fluid, tumor fragments, bits of bone marrow that may accumulate and travel within the circulation, and at any instant they can cause blockage in the circulation and leads to tissue infarction. Route of emboli: arterial emboli can cause systematic embolism, venous emboli can cause pulmonary embolism, while portal vein emboli can cause hepatic embolism. First one is pulmonary embolism. Incidence is 2 to 4 patients of 1,000 patients, hospitalized patients. So source is 95% from deep vein thrombus above the knee. This is basically, this thrombus develops in the deep vein of the leg, and due to the prolonged bed rest, due to stasis of the blood coagulates and for formation of thrombus occur in the deep vein of leg and causes the pulmonary thromboembolism in 2 to 4 patients of 1,000 patients that are hospitalized. So here you can say this is a deep vein. Here, due to any blood flow changes in the blood flow or stasis of the blood, formation of a thrombus occur. When this thrombus mass, part of the thrombus is dislodged, we call it embolus. So this embolus will travel from the deep vein to the right side of the heart, then from right side to the pulmonary artery and can block there. Leads to infarction and we call it pulmonary thromboembolism. Emboli can occlude the pulmonary artery where it bifurcates, just like in this picture. The arteries emboli blocks the side where the arteries are bifurcating. So we call it saddle embolus. Paradoxical embolus occurs when there is a defect in septal, ventricle septal or arterial septal of a heart. The emboli can pass from right side of the heart to left side and can enter into systemic circulation and can block certain sites involving in the systemic circulation. We call it paradoxical emboli. What is paradoxical emboli? When emboli from right side of the heart that is derived from deep vein thrombus, it travels to right side of the heart, then through septal defects such as in ventricle or arterial defect, it can travel from right side of the heart to left side, then enter into systemic circulation. We call it paradoxical emboli. What are the effects? The effects depend on the size, number, and clinical settings of the emboli. Few emboli with small size, basically they are asymptomatic. Little bit of infarction, pain, and dyspnea would be there. Numerous small emboli decrease the volume of pulmonary circulation sharply. Pulmonary hypertension and right ventricle failure can occur. Medium-sized emboli can cause hemorrhage and infarction. Large emboli can cause right heart failure, collapse, obstruction of 60% of pulmonary circulation. Massive sized emboli can cause sudden death, such as straddle embolus. Pulmonary embolism is the emboli blocking the arteries in the lungs or pulmonary artery, such as in the small pulmonary embolus in branch of pulmonary artery. Systemic thromboembolism, when a thrombus or when an emboli drive from heart or arteries and travel in the systemic circulation. Emboli traveling in arterial circulation. We call it systemic thromboembolism. Sources are 80% from the intracardiac mural thrombi. Mural thrombi means the thrombi that are developed in the chambers of the heart. Aortic aneurysms due to the defects in the arteries, vegetations, the emboli that develop on the walls of the heart, rarely paradoxical embolus from the venous system, as we have discussed. Target sites are lower extremities, 75% are the lower extremities, while 10% is the brain, intestine, kidneys, and spleen are affected. Consequences in function of these sites. Systemic circulation, systemic thromboembolism can cause renal failure such as renal infarction through the systemic thromboembolism. What is fat embolism? This is another type of embolism. Embolism caused by fat in the circulation. Presence of a fat in the circulation can cause fat embolism. How it occurs? Basically, source is fracture of long bone. When there is a fracture during any accident or trauma or soft tissue trauma, the fat can enter into the circulation. The results are pulmonary embolism, cerebral embolism, or other organ embolism, such as presence of the fat in the systemic circulation. How it occurs? Mechanical obstruction and biochemical injury due to release of many chemicals through by injury. Microemboli of neutral fat plus platelet and RBC aggregates. Chemical irritation, local injury to endothelium from release of fatty acids. Platelet activation and recruitment of granulocytes. Release of free radical protease and echinocytes that can cause DIC. Fat embolism syndrome (FES) symptoms are tachypnea, dyspnea, tachycardia, irritability, restlessness, delirium or coma, anemia, and thrombocytopenia. While demonstration of fat embolism, fat globules in capillaries demonstrate in frozen section of lung or brain. Presence, basically it can be diagnosed and can be seen in the frozen section of lung or brain where it causes embolism or infarction. Bone marrow embolus in the pulmonary circulation, such as this one. The cellular element on the left side of the embolus are hematopoietic cells, while the clear vacuoles represent marrow fat. These are the marrow fats. The relatively uniform red area on the right of the embolus is an early organizing thrombus. Red area is thrombus. What is air embolism? How it occurs? Trauma, chest internal jugular vein or SVC, obstetrical procedures, vascular surgery, decompression events. Pathogenesis, usually more than 100 milliliter of air needed to produce symptoms of ischemia, infarction, or DIC. When air less than 100 milliliter is asymptomatic and does not induce any symptoms. So air need to be greater than 100 milliliter. It can cause ischemia, infarction, or DIC. Where presence of air bubbles in the small capillaries can cause occlusion of the capillaries and leads to infarction and ischemia of tissues. This is decompression sickness is due to the air embolism. What is this? Decompression sickness is often seen in the scuba divers. This is basically caused by the sudden changes in atmospheric pressure. When air is breathed at a high pressure, such as seen in this picture, the nitrogen increased amount of gas, particularly nitrogen, becomes dissolved in the blood and tissues. If the diver then ascends or depressurize too rapidly, such as it moves to ascend too quickly, the nitrogen expands in the tissue and bubble out of the solution into the blood to form gas embola, which causes tissue infarction and ischemia. This is often related with the formation of bands, basically seen in decompression sickness, seen in divers, scuba divers. Nitrogen bubbles in the blood due to rapid decompression. Gas bubble occludes small vessels in joints, bone, and soft tissues, causes bands, pulmonary vessels, chokes, initiate DIC, treatment, repressurize. So after discussing decompression sickness, we would move towards another type of embolism, that is amniotic fluid embolism. What is it? It is basically obstruction complication with entry of amniotic fluid into the uterine venous circulation. That is rare but very lethal in 80% of the cases. How it occurs? Amniotic fluid contains many squamous cells, hair or fat, and mucin of the fetus that can occlude small vessel in the mother and can cause tissue infarction or initiate DIC. How it can be diagnosed? After postmortem, particulate matter are seen in the pulmonary arteries and thrombi in small vessels, and systematic fibrin thrombi seen due to DIC. So, such as next to the next slide, two small pulmonary arterioles are packed with laminated swells of fetal squamous cells. These are marked. There is a marked edema and congestion. Elsewhere in the lung contains small organization thrombi consistent with DIC. So that's the end of the lecture. If you like this video, share it with your friends, and also don't forget to subscribe the channel. We'll see you in the next video.